Well, hello everyone, and welcome to this Facebook Live, a brief that I'm going to share with you today about um, addressing the health disparities in multiple myeloma and the path to equity. My name is Dr. Joseph McHale, and I have the privilege of being the Chief Medical Officer of the International Myeloma Foundation. And I want to set the context first, and then the way I'm going to structure this today is really provide, hopefully, answers to four very important questions. So I'm going to keep this simple. We're doing this in less than a half an hour today, just so that we don't take too much of your time. But this is such an important topic, and we all need to learn a little bit more about it, and myself included, as we continue on this journey, on this path indeed to health equity. So as this is a Minority Health Month, we felt it was really important as the world has come to appreciate the significance of health disparities in multiple areas, but in particular in multiple myeloma, that we would spend some time thinking about the problem, but not just the problem, the solution. I think we can get caught up in this topic and really focus a lot on the challenges that are there, and that's absolutely fundamental. As a doctor, I can't come up with a therapy until I've understood the diagnosis. So I'm going to spend a little bit of time talking, as it were, about the diagnosis, and then hopefully talking a little bit about the solution. Not that we, as the International Myeloma Foundation, have arrived per se, but some of the things that we're doing to address this. So here are the four questions that I want to address through this seminar, through this Facebook Live event today. Number one, what is the problem? Number two, why the disparity? Number three, where is the path to health equity? And number four, what is the IMF doing? So we have what is the problem? Why the disparity? Where is the path to equity? And indeed, what is the IMF doing about it, the International Myeloma Foundation? So what's the problem here? Well, we're all, aren't we, in many respects, bombarded with data and facts and a greater realization of the tremendous health disparity in this country and across the planet when it comes to multiple myeloma. And not just myeloma, of course, but of health in general. But let's think a little bit about how this influences multiple myeloma. First of all, within the African American community, which is very significant in that 20% of all patients in this country are of African American descent. With me, of course, myself being of African descent, this is a particular sensitive and topic that hits home for me. But for many patients of African descent, patients also who are Black, this is a very concerning disease. And what are the key facts here? What is the problem? Well, the disease is twice as common in African Americans. The time from symptoms to the actual diagnosis of myeloma, which in all myeloma patients tends to take time, this is even longer, significantly prolonged, probably in the range of 6 months longer in the African American population than in the Caucasian population. Furthermore, and perhaps most worrisome, outcomes in this population are decreased. What do I mean by outcomes? I mean survival. The average survival of a Black patient with myeloma is about half that of what we see with a white patient. And none of us would ever accept in any way that that is acceptable. And we've seen great strides, and the IMF has been a big part over history of seeing this huge improvement in survival myeloma. We've doubled, if not tripled, the average survival of patients. Well, that has not been seen to the same degree within the Black population. The piece of hope, though, that I'd like to share as we think about what is the problem is that we do know that when given equal access to therapies, African Americans can do as well, if not better, than Caucasians. But as we think of Minority Health Month, there are other minorities that are significantly affected by multiple myeloma. We think of the Hispanic population, where again, the incidence of myeloma is higher than that of the white population, probably about 1.2 to 1.5 times higher within the Hispanic population. And interestingly, on average, the youngest patients are of Hispanic background. So if we think that generally the average age of diagnosis of myeloma patients is around 70 or 71, that age is about 65 or 66 in the African American population, is 64 to 65 in the Hispanic population. So this disease is clearly diagnosed at a younger age. And furthermore, we know that access to therapies and some of these critical therapies that I'm going to be talking about in a moment, these therapies that have clearly had an impact in myeloma, things like combinations of drugs, autologous stem cell transplant, CAR T cell therapy, we know it has a reduced access within the Hispanic population. Within the Asian population, interestingly, the incidence of myeloma is actually lower than what we see in the Caucasian population. And part of this, we do wonder, is if it's not been looked for. You know, we have an old adage in medicine, if you don't take a temperature, the patient doesn't have a fever. And we think that part of the challenge is that this disease has not been explored and studied and understood as well within the Asian population. We can say the same of the Native American population. Similarly, that the incidence seems to be a little bit lower than in the general population, but we know very little about this condition. And we do have areas and pockets through the country where it is felt that the incidence may be higher in certain Native American populations, and yet we just don't have enough work being done to support these patients and to understand their unique needs. So one of the things that I want us to conclude about what is the problem is, of course, there is a huge disparity. But the problem is also we don't fully understand the magnitude of that disparity. We need to learn more, and we need to dedicate our efforts to learn more. But before I get to the solution, I don't want to jump to any treatment until I have a full diagnosis, of course. I will stop there for question number one. So what is the problem? Question number two, why the disparity? So why is this? Is this just purely, if you will, a biological phenomenon, where we know that the biology may be a bit different in someone of African descent versus someone, let's say, of European descent? Well, that may be a small piece of it, and we know that it is part of the difference, although I would argue, in fact, that it doesn't really contribute to the disparity, in the sense that what we know of the difference in biology is that certain features of myeloma, what we think of as higher risk features, things that tend to give patients a poorer prognosis, are actually less common in African Americans than they are in white patients. And so it's very important for us to see that. But I would argue that the problem is much greater than that. The why of the disparity is not really just a biological phenomenon, although we tend to talk about that as doctors. We need to look at multiple issues. And in a 20-25 minute Facebook Live, I can't, of course, answer every or raise every issue, but let me just give you a list of some very important things that we need to think about that contribute to this disparity. The system as it is, the concepts of systemic racism and much of the infrastructure that we have in the country clearly affects this disparity. The socioeconomic status of patients, which indeed have been shown repeatedly to influence patients' outcomes with myeloma through multiple mechanisms, but as a phenomenon is clearly an important issue. Environmental issues, what people are exposed to. And we know, for example, that multiple myeloma is a disease where there are certain environmental exposures. We've demonstrated this with Agent Orange. We've demonstrated this, sadly, in those who lived in the area and were first responders to 9/11 and various other toxins that we have demonstrated in the environment. There are behavioral phenomena that are more common in one group of patients than others, cultural phenomena, psychological phenomena. But then one of the very important ones that I want to emphasize as a clinician, as a myeloma doctor, is access to quality care. And narrowing it down to myeloma, all of these features I've just mentioned could really very much be a template to look at the disparity in cancer in general, if not even in health in general. When it comes down to myeloma, I try to simplify it with what I call the 4 T's. We know that there are 4 things that, if you will, begin with the letter T that have had an impact in survival in myeloma. And these have sadly been shown to have reduced access in the minority populations we're discussing today. And they include triplets, or 3 drug combinations that we've shown time and time again improve survival in myeloma patients. The second T are transplants or autologous stem cell transplants. This is when patients receive a higher dose of chemotherapy, and we know that there is reduced access. Some of it is geographical, some of it is economic. There are multiple reasons why people don't access transplant. And despite all these new fancy schmancy drugs we have and approaches we have in myeloma, there is still a role for autologous stem cell transplant, and it is not being accessed by many patients. The third are trials or clinical trials. We could do a whole Facebook Live discussion on the notion of clinical trials and why it is. And thankfully, there have been great efforts through the AACR, even with the FDA. We've even recently had guidance from the FDA around inclusion of minority patients in clinical trials. But this is a real problem. If we look, for example, in the African American population, I mentioned that roughly 20% of all myeloma patients are of African American descent. And yet when we look at the trials, the average participation is maybe 5 or 6%, and perhaps even lower in what we call pivotal trials, or those trials that influence the approval of a drug. And so can we really say that this drug is effective in all myeloma patients when 20% of the myeloma population is barely represented in that trial? And so, again, I'm not trying to get to the solution yet, but I just want to give you a flavor of why we see such a disparity. So triplets, transplants, trials, and then more recently, and this is earlier data, of course, because it's just been approved over these last several months, over this last year, but CAR T cell therapy, or CAR T cell therapy is that treatment where we can take T cells out of patients, immune cells, and manufacture them in such a way that they can be put back into the patient, multiplied in fact, and put back into the patient to help destroy their multiple myeloma. And this has really been a remarkable advance in several cancers, in particular multiple myeloma, where we've seen unprecedented response. And sadly, even though it's only been a year since we've had, less than a year since we've had a CAR T at our disposal, we've already seen the disparity present within access to therapies. So why the disparity? There's a huge laundry list of things that I've discussed, but particularly focusing on those 4 T's are an area that I think we need to understand better and make sure we have as a priority for the solution. So far we've talked about what the problem is and why we have this problem, why the disparity is there. And although you may want me to stop, I'm glad we don't stop here, because there is a path to equity. Now, where is that path? How do we get on that path? What can you do in your role to be involved in that path? And it may sound trite and it may sound simple, but it really has to start with all of us. You can't just put this on the medical community or the regulatory community or the government or your neighbor. This is something that begins, I would argue, very strongly with all of us, that requires a change in our thinking. In some ways, it's going to require a change in the way our systems work and run. And I'm just Joe, right? A lot of people call me Dr. Joe, and I'm thankful for the privilege that I have for caring for patients, for being involved in an incredible organization like the International Myeloma Foundation. But sometimes it's easy to think, well, who am I? I can't change the big picture. But change definitely has to start within the individual. I've often said, when we come to talk about issues of diversity and equity and inclusion, often we think of it being a personal issue, a professional issue, and a political issue. Well, let's leave politics aside, and let's focus on it being personal and professional. Personal because it should influence the way you think. Look at your circle of friends. Look at your circle of activity. Have you come to appreciate and embrace the diversity of this country or wherever it is that you live, and understand the value that brings to our life? And also professional, in the work that we do and the workplaces where we are, this genuinely makes a difference, because I really believe if we have this genuine sense of understanding and imperative in our hearts, it's going to make a difference. But it's more than just that, of course. Let me suggest that there are 4 groups of individuals that are going to be really important in this path to equity. Yes, every single one of us individually are involved, but let's lump the community in which we live into 4 very important groups of people. The first is the lay public. just the public in general, when it comes to our path to myeloma equity, which is a absolute goal of the IMF. The IMF was founded over 30 years ago, and our founders, Dr. Brian Durie, Susie Durie, and Brian Novus, wanted us to discover a cure for myeloma. And until we reach such time, that we would support and help all patients going on this journey. And they have been committed, and we have been committed to that equity from day one. And so part of that is clearly going to involve the community at large, the lay community. And for each of these four groups, I have three words that I hope are going to help us understand. So what can the community do? Well, we want to make them aware of what multiple myeloma is. As I noted earlier, within the African American community, this is the most common blood cancer. And if there isn't even an understanding of the disease, then we're not going to be able to have a solution to the disease. We need to demystify it, as sometimes people feel that this is a sign of shame. This is not a sign of shame. This is a disease that we can confront, that we can capture, that we can treat. It may not yet be curable, but we're getting closer to the cure all the time. But it is indeed controllable. So we need indeed to have awareness. We need advocacy. We need the community at large to advocate for a path to health equity, that they need to see how important this is, that we need to be uncomfortable with the fact that some people do so well and some do so poorly. We need to understand that there is a way to improve health equity on multiple levels. And then thirdly, we need to empower individuals. I'm going to share with you in a moment what the IMF's Empower program, where we're empowering patients and communities to change the course of myeloma, because the current course of myeloma is unacceptable. And so we need to empower people. It's one thing to talk about it and raise awareness, but what are we actually doing? What tools are we giving people to really make a difference, to understand what the disease is, to help their friends, to recognize that sign or symptom they may have is something that may be indicative of myeloma, so that they go to their doctor to pick up the diagnosis earlier. We need to not just, as it were, talk about it. We need to make sure that people are given the right tools, the right information, the right opportunities to be able to make a difference. So that's group number one, the lay public. Group number two is the medical establishment. And we have a huge responsibility. And our responsibility, first of all, is in education. Right now with the era of fake news or whatever, there's people don't trust us within the medical community, and there's good reason for that, respectfully. And so it's going to take us to rebuild that trust and to provide education that is genuine, that is helpful, that is going to be honest about people and their health. We need to focus on what is now not just a popular term, but a very valuable term of cultural competent care. What does that mean? That means that me as a doctor, when I sit down with my patient, I treat them as an individual. I recognize them in their own context and treat them in a way that is going to be helpful and valuable to them. As I say all the time, I don't treat myeloma. I treat people. And so I want to understand people in their context, and people in certain cultures or backgrounds, for example, may really need someone else with them during that discussion to make the decision about going to a transplant or going to a trial or going to a certain kind of treatment. And if I'm not sensitive to that and recognize that, they want their uncle there, or their aunt there, or their pastor there, or whomever it is that's valuable to them in that decision making, I'm not being culturally competent, as it were, if I don't recognize that person's need and interest and bring that person into the conversation so that they can feel comfortable with moving forward, and not just me as the doctor saying, you'll take it and you'll like it. That's just not the way we practice medicine. And then thirdly, so it's not just about education, not just about cultural competence. I would suggest, and these aren't exhaustive lists, but these are important words, I would suggest is we have to be facilitators of access. We have to be absolutely committed to finding ways, and it's not easy. It's not simple. We don't just write a prescription in the old days and hand it to a patient, just assume that everything's going to happen perfectly. We have to understand that the system is complex and find ways within the system to advocate that our patients have access to therapies. It's just not acceptable to me that a patient, their insurance is not appropriate, or that this therapy is just not available to them. We have to find ways both individually as practitioners, whether it be physicians or nurses or pharmacists or anyone who's involved in the healthcare system, but even as a system, that we have to find a way to make this better for patients. So there's a lay public, there's the medical community, and then there's the, if you will, the corporate community. Much of this is the pharmaceutical industry and other industries, diagnostic industries. They're involved in the care of these patients. And I would suggest that they have three things that they can do as well. First of all, they have to be committed to this, and not just in name only. We've learned over the last 2 years, haven't we, that there are places and situations that may only in name only say that they're on the path to equity. And then there are those who have shown it, who have demonstrated it. It's not just about hiring a chief diversity officer, although that may be a great thing to do, but it's about having a plan, having a strategy, a commitment to do it. And within that commitment comes a strategy, so that it's not just words, but that there is a very specific strategy to ensure that we are on a path to health equity. And that can be very specific about ensuring that particular populations are being engaged and have outreach to them so that they can access these therapies. And thirdly, that they have a diversity plan. And this was actually just recently released by the FDA, is speaking about the importance of having an explicit diversity plan. When you as a company, for example, are planning a clinical trial, what is the diversity plan? Is there a diversity officer? Is this being looked at? Are you ensuring that your inclusion criteria are truly inclusion criteria so we can include patients? Are you reaching out to sites and areas where patients genuinely are? Are you facilitating people going onto that clinical trial or having access to that therapy? Or are there just barriers being popped up everywhere that prevent people from going through? And then fourthly, the last group of individuals is the regulatory community, whether it's the government or the FDA or others that are involved in this. And I think it's going to take expectations. We expect those in regulatory authority to recognize that this is a problem and to do something about it. Number two, that they are inclusive, that we don't want just to cater to a small group of people. And then thirdly, that their policies reflect that. And I think that is absolutely critical, that we have policy that looks at this. And it may be that we say, well, if you're going to develop this new drug in multiple myeloma and you haven't included a patient of African descent, which is 20% of our myeloma population, is that reflective? Is that reflective of the Asian community? Is that reflective of the Hispanic community? These are all very, very important things that absolutely have to be done. Well, in my last 5 minutes, let me hopefully bring some hope to you. So we've asked what the problem is. We've asked why the disparity. We've asked where is this path of equity. Well, let me tell you what the IMF is doing about it. Not to be a commercial for the IMF, not to pretend that we've arrived and that we're fixing everything, but I want to demonstrate my personal commitment to this and my organization's commitment to this by demonstrating some of the things that we're doing. The first four things, very quickly, in our last 4 to 5 minutes here. Number one, we want to serve as a nexus for discussion, collaboration, and advocacy. We want to be a lightning rod for these kinds of discussions. I mean, this is just a short Facebook Live discussion, but if it gets you thinking about the issue, if it gets you wanting to collaborate with others, if it gets you fired up to do something, then that's a success coming out of this. And so we want to be that opportunity to be examples even in health equity in multiple myeloma, so that even other organizations of different diseases can follow along this path. Number two, we want to engage the community. And this has been one of my greatest joys of my career these last 2 years, or year and a half or so, being engaged in the community, where we have partnered with both medical and non-medical organizations to try and address this issue. Within the African American community in particular, for example, through this Empower project that I described, we're empowering people and communities to change the course of myeloma. We partner with medical organizations like the National Medical Association or the Black Nurses Association, but also fraternities and sororities and churches and different groups that we know are embedded in the community that can help us as we seek to engage the community, to raise that awareness, to indeed educate properly and provide people the tools. Go to empower.myeloma.org. almost 250,000 of you have already gone to it, but let's bring another 250,000 to our website, where we explain myeloma, where we provide tools to understand it better if you think you may have it, where we have tools for people who have myeloma to tap into the great resources of the IMF, but also to tap locally into your health systems wherever it is you live in the country. Our third tact is to support patients through the journey. We continue to do this. We have over 150 support groups across the country. We think it's important to be at the grassroots level, supporting and helping people in any way that we can. This is an awful disease. I came out of clinic today and I saw a patient who had very high risk and challenging disease. And even my whole team knows when they walk out, they say, "Oh, Dr. Joe's going to say it." And I'm not walking out saying, "I hate myeloma, but I love my patients." And I think it's so important for us to support people through this journey. And that's been one of the four pillars of the IMF over these years of education, research, advocacy, and support to support our patients through the journey. And then lastly, to educate. And to educate the medical profession in two ways. One, we've been very committed to this issue that specifically in African Americans, but in minorities in general, we have found that there's a delayed time from the start of their symptoms to diagnosis. As I mentioned, that may be even 6 months longer. The average patient sees their primary care doctor 3 times before the diagnosis of myeloma is made, with signs and symptoms consistent with myeloma. So we've developed a targeted program to reach out to primary care providers, physicians and nurse practitioners and physician assistants and others to help them understand the early and accurate diagnosis of myeloma. That they not dismiss, especially within the African community, signs and symptoms that may speak of things like diabetes, but discriminating it from diabetes. When people have bone pain, when they have profound fatigue, when they have problems with their kidneys or a low red blood cell count or anemia, or have neuropathy or protein in their urine, these different things, the nerve problem of neuropathy plus other things like protein in their urine, all of these things could be early indicators of multiple myeloma, so that they recognize it early and then do the right testing, do the serum protein electrophoresis, the light chain testing as we need to help diagnose this disease, so they can refer them on to the hematologist oncologist. And lastly, our education efforts towards the hematology oncology community, so that we can provide more culturally competent care, so that we can provide better access to our patients. Well, as I said from the start, I by no means believe that we have come to the end of that path to equity, but I believe we are working our way down it. And I strongly encourage you to join me, join the IMF as we do this. Come to empower.myeloma.org, or even just go to myeloma.org and you'll find your way there, as we seek to address these disparities in multiple minority groups, in particular now with our African American initiative, but with multiple other initiatives, so that we can make a difference, not just in the short term, but of course in the long term, and care for our patients with multiple myeloma as we ought to. So thank you very much for your attention today, and I hope this has been helpful to you. My very best to you.